interviewing Catherine Pascarello, who was a staff operating nurse at Massachusetts Eye and Ear Infirmary.
Sure. Main responsibilities of an operating room nurse are to A, scrub next to the surgeon passing instruments, and B, be the circulating room nurse who actually runs the room in conjunction with the surgeon and anesthesia to provide the best possible care for the patient undergoing a surgical procedure.
Okay.
Most satisfying is the patient contact. Yes, it is kind of brief for an operating room nurse, but you get to really connect with people and to really make an impact on them. A lot of them don't remember, but a lot of people are extremely frightened when they're going into surgery. And if you are the last person that they see and feel, it makes that transition from being awake to being unconscious a little bit less traumatic. Moving heavy equipment is the least satisfying thing. It's very heavy, it's cumbersome. Sometimes the equipment doesn't work properly and you are expected to know how to fix it, which is not my area of expertise. Long history for that. When I was graduating high school, there were not many job openings for young women. One of them was nursing. Most popular was being an LPN, licensed practical nurse.
And for background, when did you graduate high school?
Okay. And RN's programs were not as popular. They were harder to get into. This is in 1969 when I graduated high school. I decided to take a chance and go for the RN position because I felt it would give me more opportunities than the licensed practical nurse. I also had a job working at a small local hospital where I was a patient sitter and a feeder, and decided then that was something I liked doing. Operating room nursing was something that I always wanted to do. And in the time when I graduated, they were hiring people for places like the ICU, which had just come into being in the early 70s. So I took a position there because I felt it would give me more experience, and it would be something, it was definitely something I was interested in. Patients were sicker, they were being treated with more sophisticated equipment that was being invented daily. So I went that way. Still always hoping to get into the operating room as part of my experience. And when the opportunity came up at the Eye and Ear Infirmary, I took it. I liked specializing, and I did most of my career is in a specialty field. New technology that came onto the field, you were given training classes for it. A lot of them gave you credits, some of them did, some of them didn't. And you got the opportunity to work with people who were producing this new technology. They were the ones who taught you how to use the equipment. They were the ones who taught you what to do. When I first graduated, there was no respiratory therapists, there were no physical therapists. Nurses did it all. We did everything. We were responsible for the complete care of the patient from the day they entered the hospital till the day they left.
And your initial education in the first place was not a degree program, it was a certificate training program for 2 years?
No, I went to a 3-year diploma program.
3-year diploma, okay.
Take advantage of any opportunities offered. If you decide you want to become a nurse, the challenges now are even better than they were when I came out. There's more education that's offered. There's more opportunities to stretch out in the field and to become whatever you want. I would say that you should enjoy every aspect of every course that you're given because it's a great adventure. It's a really good learning experience. You look at people very differently than just people, which is kind of hard to explain, but you do look at them. And once you get into the disease processes and how it affects the person, you look at the person as a whole, not just a disease. What skills? You need to know how to look at a patient or a person and assess what their immediate needs for health are. You need to be able to get information out of somebody who's probably very stressed out due to a disease process or the whole environment that they are in. Sometimes these people can lash out, they can be very angry, and you need to be able to look beyond the anger and the fright and the pain to the person underneath, and to be able to elicit information that is very important to have in their care. You also have to be able to make yourself available to this person on a lot of different levels, because people sometimes, when they're angry or upset or grieving, will give you information that nobody else has. And it's very important to have that information, especially when you're dealing with somebody who has a serious illness or a serious family issue that is impacting on their care. A typical workday starts out at about 6:30 in the morning, going down to the operating room and getting the schedule for the room that I'm going to be assigned to, or rooms, and putting out the equipment needed for the first one or two cases of the day. Depending on the type of cases, if you're doing a lot of small cases like tonsils or ear tubes, you would line up your first two cases. If you're doing a major case, you just line up for the first case, which means you get all of the instruments needed, all of the drapes needed, any specialized equipment like microscopes or implants, any other things that are needed in the room, like a machine that is used to put Vinadyne boots on a patient to prevent blood clots from forming while they're on the table. You have to make sure that the suction equipment is connected and functioning. You have to make sure that the cardiac equipment is functioning. You have to make sure that any medications that you need are ready and available. If they need to be mixed, you have to do that. You also have to make sure that the bed is in good working order, that the lights are in good working order, that everything is clean and everything is functioning properly. Tables are functioning properly. All of the equipment in the room is there. All the push button equipment, or if it's foot pedal run, you have to make sure that it's all working. If you're using lasers, you have to make sure that there are laser glasses in the rooms, that the signage is up, everything. Depending on your level of education and your level of interest, you're very good. You can go as far as you'd like to go. If you really want to advance in the business end of it, there are opportunities there that are amazing, and more women are taking advantage of these opportunities and really advancing themselves in their field and becoming role models for the nurses coming through. As I said, when I first graduated, ICUs had just begun. They just came into being. They were little more than oxygen tents and cardiac monitors. Any drugs that were given, like lidocaine or any other drugs that needed to be given on a time, were timed manually. There were no pumps. There were no ventilators. You had to assess your patients frequently, more often than what you do now, probably every 15 to 20 minutes to begin with, and then you progress. Patients were directly observed, which they still are. You did not have the benefit of any extra equipment except for an EKG and an oxygen tube.
It's really different.
Very different. The entry level, depending on where you start to work, probably starts $45,000 a year, depending on your level of education. If you have a bachelor's degree, you're going to come in a little bit higher. Some hospitals will compensate you for the level of education. Most do not. You will work as hard as we did, but you're doing it in a different manner.
Okay.
The MNA.
What is that?
It's the Mass Nurses Association. They also have the ANA, the American Nurses Association. If you specialize in a particular field, such as emergency room nursing, OR nursing, ICU nursing, they all have their own organizations that are directly related to continuing education in that field and furthering the cause of nurses who go into that particular specialty.
That's all I have. Thank you
That's
so
it?
much.
Oh, you're welcome.